You are so warmly welcome to this medical education session. If it's the first time you're joining us today, you are especially welcome. At Medal, we're really passionate about making medical education radically accessible for every colleague everywhere, and I hope you find today's session really useful for your practice. Before we dive in, it's really important that we share our disclosures with you, and we're just going to bring those up on screen for you just now. We have got some incredible education lined up for you today, and we're going to cover four main learning objectives today. We're going to learn how to apply advanced diagnostic strategies, including high-resolution imaging interpretation and multidisciplinary assessment to accurately differentiate idiopathic pulmonary fibrosis and progressive pulmonary fibrosis from other interstitial lung diseases, enabling earlier intervention and improved patient outcomes. We're going to learn how to delineate the complex molecular pathways that drive pulmonary fibrosis, including lysophosphatidec acid and its receptor, LPAR1, phosphodiesterase 4B, and prostacyclin, and explain their clinical relevance as targets for emerging therapies. We're going to learn how to implement individualized management plans for patients with PPF that address real-world limitations of current antifibrotic therapies, such as tolerability, perceived efficacy, and persistence, by incorporating patient counseling and adherence interventions to improve long-term outcomes in clinical practice. And we're going to learn how to interpret and apply clinical trial data on novel multi-pathway targeting therapies for pulmonary fibrosis to guide patient selection and therapy timing, supporting timely and evidence-based adoption of emerging options into practice. But before we do that, what we like to do is to ask you where you're at in your journey at the moment. And we've got some polls that I'd love to hear your thoughts on before we dive in. And these are clinical cases, and I'd love to hear how you would answer them. So the first poll is this. Mr. Rice is a 70-year-old retired attorney with a 30-pack year smoking history who quit 15 years ago. He presents with a 2-year history of dry cough and dyspnea worsening over the last year. Initial pulmonary function tests show that his FVC is 69% of predicted, FEV1 72% of predicted, and FEV1 FVC ratio 79%, and DLCO 48% of predicted. His serologies for connective tissue diseases are negative. A high-resolution CT scan demonstrates subpleural and basilar predominant reticular abnormality and honeycombing with an apical to basilar gradient. Based on the 2018 clinical practice guidelines criteria, what is the most appropriate next diagnostic step to confirm the diagnosis? And I'd love to hear your thoughts. A, B, C, D, or E. If you could share your thoughts, that would be super. I'll give you a few seconds to do that because it's quite a long case. Okay, great. Thanks, everybody. Appreciate you sharing your thoughts. Okay, super. Thanks, everybody. Some good answers coming through. If you don't know the answer, don't worry. We're going to cover all of this in our session today. So if you don't know the answer now, hopefully you will soon. Okay, the second case is this. A 65-year-old patient with recently diagnosed idiopathic pulmonary fibrosis is being considered for initiation of antifibrotic therapy. The clinician reviews the Teton 2 trial results for inhaled treprostinil and placebo-controlled trials for nerandomilast. Which of the following conclusions is most strongly supported by the data presented from these trials regarding the efficacy of these emerging agents? A, B, C, D, or E? Again, I'll give you a second just to look at that and answer. And hopefully this begins to frame our conversations today around patients, which is what this is all about. So I hope this begins to put this in context. So, okay, the next poll is this. A patient is starting treatment for IPF with a drug known to inhibit phosphodiesterase 4B and is on a 9 milligram once daily regimen. The patient reports experiencing diarrhea and weight loss, and asks for counseling on managing side effects and ensuring adherence. Based on the tolerability and side effect profile data, which of the following is the most accurate counseling point for this specific medication? A, B, C, D, or E? If you could share your thoughts, that would be super. If you're just joining us, we're doing some polls. You will find them on the right-hand side. If you're on desktop, you'll find them by clicking the little chat icon if you're on mobile. And if you're joining on one of the other platforms, you're going to have to join on Metal next time to participate in our polls. But you'll find all of them there. And if you've missed one, don't worry, you can scroll up and see the other ones. Okay, the next question that I'd love to ask you is this. The inbuilt trial, which investigated nintedanib in patients with progressive pulmonary fibrosis, excluding IPF, demonstrated a statistically significant reduction in the annual rate of FVC decline. The results showed that the adjusted annual rate of change in FVC was a decline of 80.8 milliliters in the study group versus the decline of 187.8 mil in the placebo group in the overall population. Which finding from the inbuilt trial provides the strongest evidence to support the adoption of this therapy for patients with PPF? If you could share your thoughts, that would be great. And again, if you don't know the answer, don't worry. If you've missed one of our polls, you can scroll up and find them all. Super. Okay. And then this one. Regarding key molecular pathways driving pulmonary fibrosis, which of the following is an accurate pairing of a molecular target and its corresponding therapeutic mechanism of action as an emerging therapy? Great, thanks everybody. Okay, almost there. The high-resolution CT imaging criteria for a usual interstitial pneumonia pattern requires the presence of honeycombing and a subpleural basilar predominance. Which of the following is a feature that is inconsistent with a UIP pattern on high-resolution CT and would favor an alternate diagnosis? Super. Thanks, everybody. Okay, our penultimate quiz question is this. When counseling a patient who's starting nintedanib for IPF regarding potential limitations and side effects, which of the following is a recommended management strategy for the most notable adverse event? A, B, C, D, or E? And our final quiz question is this. The core signaling pathway for fibrosis involves the migration and proliferation of fibroblasts leading to the formation of myofibroblasts. Which of the following molecules or cytokines are activators in this core signaling pathway? Okay, and if you don't know the answer, don't worry. Again, we're going to cover it all in today's session. And the final thing I just want to ask you in real quick, rapid fire, is how confident you are in these topics before we start. So before we begin, how confident are you in applying high resolution imaging and multidisciplinary assessment to differentiate IPF and PPF from other interstitial lung diseases early and accurately? 1, not confident, up to 5, very confident. Just going to rattle through these ones. Before we start, how confident are you in recognizing the key molecular pathways driving PF, including LPA, LPAR1, phosphodiesterase 4B, and prostacyclin, and the relevance to emerging therapies? 1, not confident at all, right up to 5, very confident. And then before we start, how confident are you in implementing management strategies to address antifibrotic therapy limitations through patient counseling and adherence support? 1, not confident at all, right up to 5, very confident. Great, thanks everybody. And the final question, and then we're going to dive into some amazing education, is this. Before we start, how confident are you in interpreting clinical trial data on multi-pathway PF therapies to guide patient selection and evidence-based adoption? 1, not confident at all, right up to 5, very confident. Super. Great. Thank you so much, everybody. Really interesting to see where everyone's at. And I hope by the end, if you're not sure about some of the answers, you will be. And hopefully that begins to frame what we're going to learn today around patient. Okay, so it gives me great pleasure to introduce our speaker today, who is Professor Corey Kershaw. And Professor Kershaw is a professor in the Department of Internal Medicine at UT Southwestern Medical Center. And he's also the Clinical Services Chief for the Division of Pulmonary and Critical Care Medicine at UT Southwestern. And he's going to be leading our session today and covering all of our learning objectives. We're going to have some time for questions at the end. So please put any questions you've got in the chat box. This is an amazing opportunity to ask a world expert whatever you'd like to understand. So please place your questions in the chat box, and we'll be honored to pose those questions to Professor Kershaw after his presentation. I'm going to hand straight over to Professor Kershaw.
Hello, everyone. Today, I will be speaking to you about emerging therapies in pulmonary fibrosis care for 2025. These are my disclosures available to you. And this is our assignment today, our learning objectives, and I'll leave those up for just a second. And what we're going to do today is we're going to talk through a case. And this is a fairly real world case for a typical patient, but the details have been changed. So first of all, what's wrong with me? So our patient is Mr. Rice. He's a 70-year-old man. He comes to clinic with at least 2 years of a daily dry cough. His family reports that he's probably been coughing longer than 2 years. He walks daily for exercise, but has noticed that his usual walk is resulting in a bit more shortness of breath than he thinks is normal. And also he notices shortness of breath with, for example, showering in the last year. This has been getting worse. His primary care provider, he brought this to his PCP's attention. He was treated for seasonal allergies, including some nasal steroids. This did not help his symptoms at all. He was subsequently referred to a cardiologist, given he has a history of smoking and also high blood pressure. However, workup was negative, including a stress test. He has high blood pressure, as I mentioned. He has prostate disease. He's a former smoker, 30-pack years, quitting 15 years ago. He worked as an attorney. He's now retired. During the history, he reports no environmental exposure of concern. Specifically, he has no concerning pets, such as birds with feathers, birds in cages in the home, no mold or history of water damage in his home that he's aware of. You review his medications, and there's no concerning fibrogenic medications in his history. He has no family history of specifically interstitial lung disease. We do a workup for possible connective tissue disease association. Blood tests are negative, and there's nothing on his exam or history suggestive of an underlying connective tissue disorder. The only thing you find on exam is he has some fine crackles in both lung bases, but nothing else really of note at all. We get pulmonary function testing on the patient. His vital capacity is below normal, 2.73 liters, or 69% of predicted. He is not obstructed. And his diffusion capacity is moderately impaired, 12.61 or 48% of predicted. And we have this representative example of his CAT scan. And we will talk in some detail about the features of the CAT scan shortly, but this is his scan that you see in clinic. So let's talk about idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is an interstitial lung disease that has both a radiological and or histological pattern of usual interstitial pneumonia, or UIP. I'll use the term UIP throughout this presentation, in the absence of a cause. And this means there's no environmental factors that you could ascribe to the ILD, no associated systemic diseases such as connective tissue disease or autoimmune disease that could cause ILD, and really no other causes for the ILD. So if you have someone with a UIP pattern, either on CT scan or pathology, no cause, you very likely have a diagnosis of idiopathic pulmonary fibrosis. There's some nuance to this that I'm not going to get into today, but I'm happy to answer any questions later on about those nuances if anyone has them. There are some risk factors for IPF. Older age is a risk factor. Men tend to be affected more than women. And actually, a smoking history is more commonly associated with IPF. Cause and effect is a little bit difficult to determine, but there certainly is at least an association there. The incidence is rising, and certainly depends on which country you're studying, anywhere from 1 to 13 cases of IPF per 100,000 persons, and the highest prevalence is in Korea, the United States, and Canada. This could be ascribed to just better reporting in those countries, but at least that's where you'll see the most prevalence. On the right, you'll see a graph that describes IPF. Most of us understand that IPF is a progressive lung disease. However, the rate of that progression is incredibly variable. No one patient behaves the same. You may have patients that progress slowly over time. You may have patients that progress more rapidly, or even declining within a few years. There are some people who do well for a long time, but they may have these bouts of exacerbations that result in rapid worsening of their lung disease. And what we do know about the exacerbation phenomenon, that should a patient recover, they may continue to progress either at their prior rate or a faster rate, but they typically never recover the lung function lost during the exacerbation. We'll talk a lot today about the different mechanisms of the fibrosis process, but in simplest terms, it's the result of an alveolar epithelial cell injury of unknown cause in IPF that results in aberrant healing of the injury. This aberrant healing results in progressive fibrosis that often is irreversible, especially in the case of idiopathic pulmonary fibrosis. So the concept is injury, healing is done poorly, leading to fibrosis. This is just an example of the myriad mechanisms of fibrosing ILDs. And I think, as I said before, the commonality is there is some inciting damage. In IPF, that damage is of unknown cause. However, the damage could be from other factors if you have an ILD of known cause. For example, chronic inflammation from an exposure in your environment, the autoimmunity that we see in connective tissue diseases, resulting in epithelial cell activation damage. And this process may result in normal healing, as you'll see there. In fact, that probably happens most of the time. Most of us aren't aware that we are undergoing alveolar epithelial cell damage because the lungs heal normally. But for reasons unknown, there certainly is some susceptibility, as you can see there on the right hand of the slide. Some patients heal aberrantly. There's multiple cytokines and fibrotic signaling mechanisms that lead to this process. IL-4, IL-13 are some of the implications. Implicated cell signaling mechanisms that lead to activation of TGF-beta1, PDGF, and we end up getting migration and proliferation of fibroblasts into this extracellular matrix that has a differentiation of the fibroblasts into myofibroblasts, laying down a fibrosis that again progresses over time. The way I like to explain this to both providers that I'm educating or even patients is that it's like the process is like hitting a row of dominoes that progress. Once you hit the first domino down, things start to fall in a lot of different pathways if you have them lined up a certain way, and you may stop the falling of dominoes in one row, but it tends to progress down the other rows. So once this process starts, it's very difficult to reverse it. And the reason for that is that there's so many different pathways that the fibrosis can occur down. It's hard to stop it with just one intervention along one of those pathways. Some of the risk factors for patients to heal aberrantly: cigarette smoking, as I mentioned before. We know that some patients have mutations in the telomere genes that predispose them to early fibrosis and progressive fibrosis. And there is at least one promoter variant in the MUC5B gene that we can see here that we know that also predisposes patients to having more fibrosis than someone without that mutation. It's really incumbent upon us as providers to determine what type of ILD the patient has. It's very common in our practice for us to think of all fibrosing interstitial lung diseases as being IPF. And as you can see from this slide, this simply is not true. There are innumerable types of interstitial lung disease, and one of the first duties we have as providers is determining where they fall along this pathway. I think that a very simple way to think about this is that you have ILDs of known cause and ILDs of unknown cause, or idiopathic interstitial lung disease. There are some rare lung diseases you can see there on the right, granulomatous ILDs, and then this other category that includes some rare lung diseases that I won't talk about today. But if you look down the pathway of idiopathic interstitial lung diseases, you'll see there's really 6 major phenotypes there. There's smoking-related ILD, there's acute ILD, and then there's the fibrosing ILDs, which include IPF. When we see a patient for the first time, the most important thing that we do is take a detailed history. We can very often determine the type of ILD the patient has just from taking the story. So these are the things that we have to ask our patients at that first visit. Describe their symptoms. Do they have shortness of breath or cough? Dry cough is typical, but not universal. We have plenty of patients that have productive cough, and that's just the flavor of their disease. The timing of the symptoms. Is there symptoms of onset over a few days, or is it weeks to months? An IPF history typically is more insidious in terms of the symptoms, occurring over weeks to months. We want to take a detailed occupational and environmental history. This gets at exposures. The things that we're exposed to that typically lead to a fibrosing ILD occur in places where we spend most of our time, and that's work and home. So you want to really get a good idea of what the job environment is like, what the home environment is like. Are there potential exposures there? A smoking history, not just because there are smoking-related ILDs, but as I said before, a smoking history is a known association with increased incidence of IPF. Do they have any unusual hobbies, things like woodworking? Do they compost their own fertilizer? Do they play any wind instruments that involve reeds? These are other areas where they could be exposed to perhaps mold that could lead to ILD. A very thorough medication history is necessary, not just what their current medications are, but what their past medications are. I've listed some of the more common medications there. I always ask about amiodarone. I always ask about chronic urinary tract infections where someone may have taken nitrofurantoin for weeks, months, or years as a suppressive antibiotic. And then I always ask about other autoimmune diseases or cancer history, because a lot of the medications we use for those diseases can lead to lung fibrosis. If there's any doubt, there's a wonderful website called pneumatox.com that you can enter in the name of the medication, and it will give you the frequency with which that medication has been reported to cause some lung side effect. These are usually case reports, and you can find links there that will take you to the reports. You can read them yourself. You know, it's difficult to ascribe an ILD to a medication if there's just been one single case report of the medication. But if it's been, 20 or 30 case reports, or even reported during a clinical trial of the medication, that could be more compelling. Associated symptoms, and this really gets at other causes for the ILD. A lot of the things you see here symptom-wise are related to autoimmune diseases. So if someone has arthritis, if they have difficulty with their swallowing, recurrent fevers, pleuritic type chest pain, that may point toward an autoimmune disease. So that should be a red flag that we need to pursue a little more further. These are just a list of some of the connective tissue disease associated serologies and their disease associations. These should never be considered diagnostic by themselves. It's not unusual at all to see a patient who may have a single isolated positive ANA, for example, or a rheumatoid factor that's elevated. But if there really is nothing else to go along with the disease besides just a random antibody that's maybe mildly or even moderately positive, that should not be considered diagnostic by themselves. We may need to bring a rheumatologist into the conversation to further work up the patient for the possibility of a systemic autoimmune related disease. After we've taken this history, this is a really nice algorithm that was published in 2022, the last diagnostic algorithm for IPF, that takes us through step by step of how we make this diagnosis. After we have reviewed all the potential causes and the associated conditions that might cause the ILD, we then need to consider the high-resolution chest CT. It is, along with the history, one of the most important components of making the diagnosis, because combined with history, we can often arrive at a diagnosis without needing to do anything else. So let's talk about that a little more further. These are the example HRCT interpretations that we can use. This is the language we use in interpreting the CT scan. So there is a UIP pattern. Sometimes we say a definite or a typical UIP pattern. There's a probable UIP pattern. There's indeterminate for UIP, and then not at all consistent with UIP, and we should consider an alternate diagnosis. This is the language the radiologist should be using when they interpret an HRCT in the context of a possible fibrosing interstitial lung disease. What do those look like? So this is an example of a UIP pattern on HRCT. The typical pattern of UIP is one that is subpleural and basilar predominant in its disease, or an apical to basilar gradient. So that's definitely something we want to look for. Is the disease worse at the bottom of the lungs than at the top? We should have a reticular abnormality. This just means extra lines or scar. That's really the fundamental type of scar, the extra lines, the reticulations in a subpleural distribution. The small arrows you see on your screen there are pointing at those reticulations, subpleural reticulations. A requirement for a definite UIP pattern is that you should have honeycombing type fibrosis with or without traction bronchiectasis. What does that mean? Well, the honeycombing fibrosis is just what it sounds like. It's fibrosis that looks like the honeycomb you would see in a beehive, and you can see some of those areas both in panel A and panel B. Traction bronchiectasis refers to areas where the airways are more dilated than they should be, but it's not because of intrinsic airway disease. It is due to microscopic fibrosis around the airways. I'm going to use my cursor here for 1 second and use this arrow. This is an excellent example. I'm circling right there with the arrow of traction bronchiectasis. This airway is much more dilated than it should be. We should never see an airway in that location on a typical CT scan, but it's not because the airway is diseased. It's because of fibrosis around it, pulling open the airway, dilating it by traction. This is the honeycombing fibrosis you see here. There should be an absence of features listed as inconsistent with UIP. These are lots of cysts, lots of nodules, extensive ground glass or inflammation, or some unusual distribution. It's more central than peripheral. It's more apical than basilar. Those are things that argue against a typical UIP pattern. If you have all four of these things, subpleural and basilar, reticulations, honeycombing, absence of inconsistent features, there is an almost 100% concordance with UIP on surgical lung biopsy. So what does that mean? If you have these features on HRCT, you should never do a lung biopsy because it's not going to add any data and you're merely putting the patient at increased risk of perioperative morbidity. So don't do it. If you have a UIP pattern on CT scan, do not do a biopsy. And this is a great example of that. We have honeycombing fibrosis here. I'll use my cursor again. Honeycombing fibrosis here along the periphery. We have traction bronchiectasis here. We have lots of extra lines, and we have no discordant features at all. This is a typical UIP pattern. So what's a probable UIP pattern? Basically, it's everything but the honeycombing. Apical to basilar gradient, reticular abnormalities. You could have a few of those discordant features, but it cannot be a dominant feature. Mild ground glass opacities, you see some of that on the CT scan here. If you have three of the four, everything but the honeycombing, you also very likely will have UIP on surgical lung biopsy, up to 85% concordance with a probable UIP pattern. So another example of someone that should never have a lung biopsy. And the latest iteration of the IPF guidelines tell us that if the patient either has a definite UIP pattern or a probable UIP pattern in the absence of a cause, you can arrive at a diagnosis of idiopathic pulmonary fibrosis there, and you don't need to do anything else. And indeed, for the purpose of clinical trials, these are the patients we enroll, patients with either definite or probable UIP patterns on CT scan without a cause. The reason I keep bringing up the idea of without a cause is because UIP is not unique to IPF. You can have a UIP pattern in numerous other entities, drug toxicities, exposure-related lung disease, such as hypersensitivity pneumonitis, systemic autoimmune disease, radiation fibrosis, asbestos exposure can all cause a UIP pattern. So indeed, IPF is UIP without a cause, but UIP does not necessarily equal IPF. So this may answer the question some of you may have, why not just do the HRCT? This is why. Because if they have UIP, but there's a reason for it, that does not equal a diagnosis of IPF. What about progressive pulmonary fibrosis? So this is something a little bit different. If someone has a diagnosis of progressive pulmonary fibrosis or PPF, it really implies a non-IPF diagnosis. So these are all those other things I talked about, either an unclassifiable ILD, NSIP, hypersensitivity pneumonitis. And if they meet two of these three criteria within 12 months, then you could diagnose them with progressive pulmonary fibrosis in a non-IPF diagnosis. So those criteria are worsening respiratory symptoms, physiologic progression, and you can see the definitions of physiologic progression there, or radiological progression worsening on the CT scan. If you meet two of those three criteria within 12 months, then you can diagnose your patient with progressive pulmonary fibrosis, even if they don't have an IPF diagnosis. Why is this important? This is why. This is a slide that shows the progression of forced vital capacity decline over 52 weeks in 2 separate clinical trials. The lighter blue curve is the placebo group from the Impulsus trial. Impulsus was the study that randomized patients to nintedanib versus placebo with IPF. So this is the placebo group. These are patients with IPF. So these are patients with IPF that were not taking anything. The INBUILD group, those are all the purple lines. INBUILD was a study also of nintedanib for progressive pulmonary fibrosis. So everyone in INBUILD met criteria for progression. And I show you this because you'll notice that patients with progressive pulmonary fibrosis progress at about the same rate as patients with IPF not on therapy. What this means is that progressive pulmonary fibrosis loses lung function at a similar rate. And the change is the same even if the patients have some other pattern besides UIP. Progressive pulmonary fibrosis is a serious diagnosis and warrants attention and possibly some therapy, and we will talk about that shortly. What about other diagnostic procedures? So in that algorithm for diagnosing IPF, there were some things after the HRCT, including possibly lung biopsy, possibly multidisciplinary discussion conference. So what about doing a bronchoalveolar lavage? Does that help me at all? The only value to doing a bronchoalveolar lavage in the workup for an interstitial lung disease is to exclude other things. It's typically not going to help you with the fibrosing ILD diagnosis. But if you suspect something unusual, an eosinophilic pneumonia, for example, if you think the patient has an infection, the BAL can be very helpful in making those diagnoses. But doing a BAL with or without biopsy, such as a cryobiopsy, in order to ascertain the type of ILD your patient has, the fibrosing ILD, it typically is not going to be very helpful. If you do want to do a biopsy, such as a bronchoscopic cryobiopsy, as an alternative to a surgical lung biopsy, it really needs to be interpreted in conjunction with a multidisciplinary discussion conference. This is where we discuss cases with a pulmonologist, a thoracic radiologist, a thoracic histopathologist, and go over these cases together. That really is, you cannot use a cryobiopsy by itself without also having this MDD conference to discuss all the data together, the cryobiopsy just being one part of that. This really is to be used for patients with non-UIP patterns. As I've stated repeatedly, you should not be doing tissue acquisition procedures on patients with UIP patterns. So we return to our patient, Mr. Rice. He has a definite UIP pattern on HRCT because he has an apical to basilar gradient. He has reticulations and a subpleural distribution. He has no discordant findings. He has honeycombing on the CT scan. We therefore diagnose our patient with idiopathic pulmonary fibrosis. So let's move on to Mr. Rice today, who has questions about if he can be treated. He listens to the diagnosis, and after this, he's quiet for a bit. I've heard about this disease, doc. There's no treatment for this, right? But we're going to reassure him today. Actually, we have now 3 options available that can slow the progression of IPF. So the first option is the newest option. This is nerandomilast. Nerandomilast is an inhibitor of phosphodiesterase 4B. And via this mechanism, we may be able to de-differentiate myofibroblasts in the lungs. So as I said earlier, the fibroblasts begin to differentiate into myofibroblasts, leading to collagen deposition, progressive fibrosis. The phosphodiesterase 4B pathway may be able to stop that differentiation and hopefully halt the fibrosis cascade. It also interferes with other fibrotic signaling pathways such as TGF-beta. That's a very important signaling pathway in the fibrosis process. And in a phase 2 trial, lung function was stabilized over a 12-week study with a favorable safety profile. So nerandomilast went on to a phase 3 study. Patients were randomized in 3 groups, 18 milligrams of nerandomilast twice per day, 9 milligrams twice per day versus placebo. This is a pill. It's something oral. And background antifibrotics were allowed. So patients could take the other 2 FDA-approved antifibrotic medications for IPF. That's nintedanib or pirfenidone. Enrolled almost 1,200 patients with IPF, 40 years of age or older. And they had to have, mild to moderate disease, FVC greater than or equal to 45% of predicted, and a diffusion capacity greater than or equal to 25% of predicted. And what we can see is, you can see on the panel on your right, that at 52 weeks, the progression of patients taking the 18 milligram, and indeed actually the 9 milligram dose of nerandomilast, the progression was much slower than patients who were not taking nerandomilast. One little wrinkle to the study, just because this is the world we live in today, most of the patients were already taking antifibrotics. 77% of patients were already on some antifibrotic, either nintedanib or pirfenidone. So what about the combination of therapy? Well, first of all, I'll say that the study was not powered to analyze subgroups. So this is a common question. What if I take two medications at one time, nerandomilast plus something else? Well, we cannot say with a high degree of certainty that two of the medicines together are better than one. But I think it's worth at least looking at some of the subgroups because they were published. These are patients that were taking nothing. So these are patients that, so you'll see the nerandomilast 18 milligram group and 9 milligram group, these are patients on nothing else, versus placebo, so nothing else at all, no background antifibrotics. The progression was quite slow, 80 cc's, 70 cc's in 52 weeks. That is a tremendous improvement in patients who weren't taking anything versus placebo, 150 cc's in a year. What about taking background nintedanib? Still made a difference. And same thing with pirfenidone, still made a difference, but I will point out that in the 9 milligram group, there was no difference with placebo. And the speculation is that there's something about nerandomilast that interferes with the metabolism of pirfenidone, perhaps metabolizes it more quickly than without nerandomilast. Therefore, the patients don't really get good therapeutic levels of the drug. And therefore, what came out of this study is that patients who are taking pirfenidone and you say you want to add nerandomilast, you should not add the 9 milligram dose to them because it's not really going to make a difference. Whether truly combination of therapy is better than one versus one of the others is really an unknown question. So pirfenidone, the second of the 3 FDA-approved medications, this was studied and published in 2014. 555 patients with IPF randomized to either oral pirfenidone or placebo for 1 year. Pirfenidone is a 3 times a day medication, so the dose was 801 milligrams taken 3 times per day. The endpoint was the change in vital capacity or death, a combination or composite outcome at week 52. And you'll see here that at multiple interval assessments at week 13, 26, 39, and 52, pirfenidone slowed progression relative to patients not taking pirfenidone. And you can see the rate of change in FVC over 52 weeks was much better with patients taking pirfenidone versus placebo. And because of this, pirfenidone was approved for the treatment of IPF. The third option is nintedanib. Nintedanib was studied in 2 parallel phase 3 trials published in 2014. There were a total of a little over 1,000 patients with IPF randomized to either nintedanib, and the dose for nintedanib is 150 milligrams twice per day, another oral medication, versus placebo. Primary endpoint was the annual rate of decline in vital capacity in 1 year. And you'll see, again, as I mentioned, 2 parallel phase 3 trials, Impulsus 1 and Impulsus 2. And in both of those phase 3 trials, the rate of change in FVC at 52 weeks was much slower in patients taking nintedanib versus taking placebo. Therefore, nintedanib was approved to treat IPF in 2014. So again, we have 3 options now to treat our patients with IPF. What about progressive pulmonary fibrosis? Well, as of today, there is only 1 approved medication to treat progressive pulmonary fibrosis. And again, this is important because patients who begin to progress with their non-IPF ILD, they behave much like patients with IPF not taking anything. So we really need to appropriately address these patients as urgently as possible. So this is the InBuild study. This was a study of patients with progressive pulmonary fibrosis over 52 weeks. IPF, as I said before, was excluded, and most background therapy was excluded. So if you have a patient who has, let's say, a connective tissue disease associated ILD, so oftentimes those patients are already taking some, immunosuppressive anti-inflammatory medication. So those patients were not allowed in this trial. That's an important point when we're thinking about what to do for our patients, because if someone was already taking one of these medications, it's a little bit uncertain how much nintedanib is going to help them, but it certainly is the only FDA-approved option for them. 663 patients, half the patients had either exposure-related ILD, hypersensitivity pneumonitis, or a connective tissue disease-associated ILD. More than half the patients had a UIP pattern, and there was an improvement in patients' progression with progressive pulmonary fibrosis. The progression indeed was slowed down if they took nintedanib versus taking nothing, and it really bore out whether they had a UIP pattern or not, as you can see here in the graph. So because of this, the FDA approved nintedanib to treat progressive pulmonary fibrosis. So we move on to the next part of our discussion with Mr. Rice. After we have discussed all of the FDA-approved options to treat IPF, including the possible side effects and expected outcomes, Mr. Rice is overwhelmed by all of this. We will discuss side effects here in more detail as part of the talk, but let's assume we've already discussed those with Mr. Rice. He's really overwhelmed. He asked, is there anything else we can do? What about research trials available to me? Well, in 2025, this is a very exciting time to be an ILD-specific pulmonologist. Because we have a really good understanding of all the possible mechanisms that fibrosis both occurs and progresses, that offers the opportunity for multiple therapeutic targets. And this is just some examples here. We have targeting the epithelial signal that starts the fibrosis cascade. We have macrophage signals that are potentiators of the fibrosis. We have these mesenchymal signal targets that help with the fibrosis, the fibroblast to myofibroblast transformation that's more later or distal in the fibrotic cascade. This affords multiple opportunities for research and future clinical trials. Some of the medicines that I have lines crossed out there, these are medicines that have been studied already and did not progress past the phase 2 or phase 3 to approval because they were a negative study. So I'm going to talk about some of these emerging therapies today. So the first one focuses on the lysophosphatidic acid pathway. Lysophosphatidic acid mediates the fibroblast migration into the alveolar space in patients with IPF. If you take mice that have a knockout of the lysophosphatidic acid receptor, that was protective of having bleomycin lung injury in a mouse knockout model. So if we could somehow antagonize these lysophosphatidic acid receptors, this affords an opportunity to slow the fibrosis pathway. So indeed, there is one of those available for research right now. That is admilparant. Admilparant is an LPA1 receptor antagonist, and in a phase 2 study, as you can see here on the right, it slowed the progression of vital capacity loss in a cohort of IPF, as well as a separate cohort of progressive pulmonary fibrosis. This will be a recurring theme because the progression is parallel to patients with IPF. The mechanism is also theorized to probably be very similar also, as I showed in one of my earlier slides of the mechanism. Therefore, most of these emerging therapies both have trials for IPF as well as progressive pulmonary fibrosis. Because of this improvement in the rate of progression of FVC loss, admilparant moved on to a phase 3 study. That phase 3 trial is ongoing for both cohorts right now, drawing to a close. So we should have results for the admilparant study probably in the next 12 months or so. So stay tuned for that. Hopefully we'll have good news coming from the admilparant study when it closes. In health, treprostinil. Treprostinil is a prostacyclin analog. Treprostinil is a well-known medication to those of us who manage pulmonary hypertension because it's a pulmonary artery vasodilator. It has used both systemically from an IV or subcutaneous form to treat pulmonary hypertension. There is an oral form of treprostinil and there is an inhaled form of treprostinil. In a trial called INCREASE, there was this INCREASE was a study of patients with lung disease associated pulmonary hypertension. This is a real source of trouble for many of us who take care of these patients because most of the medications to treat pulmonary hypertension exclude patients who have lung disease because there's some contraindications with vasodilation, the pulmonary artery side, that could actually result in paradoxical worsening of hypoxemia. So it's difficult to use these systemic therapies to treat pulmonary hypertension when it's due to lung disease. You could actually make the patient worse. Inhaled therapies have been of interest because then you're not delivering the medicine systemically, you're giving it at the alveolar level. So perhaps this could just help patients where they're ventilating and help their pulmonary hypertension without worsening their hypoxemia. So this was a trial to do that. And indeed, it turned out that it was a positive trial. Patients with PH from lung disease, they had improved 6-minute walk time. So we now have another option we have actually the first option to treat pulmonary hypertension associated with lung disease. But there's some unusual features of these prostacyclin analogs. They actually have distinct antifibrotic properties via inhibition of the TGF beta pathway that stimulates collagen production from these fibroblasts. There's also some extracellular remodeling that's done that reduces fibrocytes entering these sites of vascular remodeling. So in addition to its vasodilator effects, perhaps it could also help fibrosis. And in a subset analysis published in 2021, we actually showed that patients who had ILD had an improvement in their vital capacity in this pulmonary hypertension trial. So this was huge news when this happened. And because of that, there has been a dedicated trial to use inhaled treprostinil to treat the fibrosis itself. So this is the TETON study. So TETON is enrolling patients who have a forced vital capacity of greater than 45%. If they are allowed to be on background therapy, as most of these trials will, and appropriate diagnosis of IPF and a recent HRCT. There are 2 trials ongoing for TETON. There's TETON 1 and TETON 2 for IPF. And the TETON 2 study, which were all the patients outside of the United States and Canada, this data was presented at the European Respiratory Society meeting in September of 2025, and it was a positive study. So it showed that patients that were randomized to inhaled treprostinil versus placebo had a slowing of their vital capacity loss at 52 weeks. This was very, very exciting. The TETON 1 study is also drawing to a close, so we should have those results soon. And as I said before, there's actually a TETON PPF arm to treat patients who have progressive pulmonary fibrosis with inhaled treprostinil. So stay tuned for that. We should have those results soon. But right now, we're sort of getting a signal that we may have another medication coming for us soon, that being inhaled treprostinil to treat idiopathic pulmonary fibrosis if the TETON 1 bears out the way TETON 2 did. What else is coming? Well, there are multiple things in phase 2 trials going on right here. I'm not going to read this list, but this is just an example. These are 8 phase 2 trials that are either ongoing or have drawn to a close and maybe moving to phase 3, but all of these were positive studies. So either ongoing or the ones that were completed were positive studies. So as I said before, this is a very exciting time to be involved in taking care of patients with fibrosing lung diseases because the research is moving so quickly. There are many therapeutic targets, as we saw earlier, and some very smart people in the industry are working on the research to find appropriate targets to try to slow down the fibrosis process. So hopefully there'll be even more options available to patients down the road as research continues. Okay. Our patient asked, I would say, the most important question of all this. We spent a lot of time talking about pulmonary function testing changes. We're going to make the vital capacity look better. And the doctor, Mr. Rice, is very appreciative of all this. Thanks so much for giving me all this information. I'm really encouraged, and I'm going to feel better, right? I mean, my cough, my shortness of breath, all that's going to get better, right? These medications are going to make me feel better. Well, maybe, maybe not. Anytime we discuss treatment of these diseases with our patients, an important part of that educational process when we're telling them about the options to treat, we have to tell them what the downsides are. These medications carry side effects. This is pirfenidone. The most common side effects of pirfenidone are nausea. I would say the dyspepsia, acid reflux is also fairly common. And there's also this issue with a sun-sensitive rash. This is unique to pirfenidone. So you have to tell patients that you prescribe pirfenidone to, they have got to cover all their skin when they go outside. That includes sunscreen, covering exposed skin with sleeves, pants, etc., because a sun-sensitive rash is very common. As you can see here, and this is the original pirfenidone study, 28% of the patients had a rash versus only 8.7% of patients not taking pirfenidone. I also counsel patients about the anorexia and weight loss. This is not unique to pirfenidone. Nintedanib also has this side effect, and it can be really disconcerting for patients. What? I'm just not hungry anymore. I'm losing weight and I'm not trying to. These are known side effects of these medications. So we have to counsel patients about this and tell them to be very conscious of their diet because they may lose weight, and we need to start looking for alternatives to help them hold on to weight if this is something alarming for them. Another thing that's a little bit problematic when prescribing pirfenidone is the pill count. The top dose of pirfenidone is 3 tablets 3 times per day, so 9 pills per day. That's how you get to the total dose of 801 milligrams 3 times per day. There is a single 3-tablet to 1-tablet conversion available. So the small tablets are 267 milligrams. There is a single 801 milligram tablet. So if patients do get to the top dose, you can convert them to the single tablet, but it's still 3 times per day. So often when we're discussing pirfenidone with patients, this can be a bit of a turnoff to them to have to take a medicine 3 times per day. And that's just the way pirfenidone is. So I find that in my own practice, just to speak anecdotally, if people are not willing to try pirfenidone, it's usually one of 2 things. They're not willing to wear sunscreen. They don't want to take a pill 3 times per day. So it's important that they know that up front. Nintedanib. One of the interesting things about the pulmonary fibrosis patient population is that these are often well-educated patients, meaning well-educated about their disease. When they come, they at least have done some research if they're concerned about this. And patients who read about nintedanib, they're going to know about diarrhea. The diarrhea of nintedanib is very common. It's well over 60% of patients who take nintedanib will have some change in their bowel habits. They also can have the anorexia and weight loss because of the mechanism of action of nintedanib. Bleeding is a side effect, potentially. The most common bleeding side effect in the Impulsus trial was nosebleed, thought to be due to the dryness that patients get if they're on oxygen, predisposing to bleeding from the nose there. So you should have at least a little caution if patients are already predisposed to bleeding, either because of a bleeding diathesis or because they're taking systemic anticoagulation. Once again, anecdotally, I have not found this to be an absolute contraindication to taking nintedanib if they're on some sort of anticoagulant, but it should be part of the discussion and shared decision-making with a patient so they're aware of this side effect. What can you do to mitigate the diarrhea? Well, one of the absolute requirements about nintedanib is you have to take it with a full meal twice. So your twice per day dosing of nintedanib must be taken with a full meal, and that meal must include protein. So if you have a patient who their breakfast is a piece of toast, a cup of coffee, they take their nintedanib, they will have diarrhea. So that requires some education, perhaps a visit with a dietitian to discuss how can I help with eating properly to help with the diarrhea side effect of this new medication my doctor put me on. Loperamide can be helpful if patients are really struggling with the diarrhea. Taking loperamide is an option. And also holidays. So what does that mean? That means just taking a break, maybe taking a weekend off, maybe taking a week off. This is a common thing to do to help mitigate the side effects of nintedanib, just resetting the bowel, so to speak. So once again, this is an ongoing process. We have to talk to our patients about this every time we see them, how they're doing with the medication, and what can we do to help them so that they continue to benefit from the medication and not have the side effects be so outweighed. Nerandomilast has some advantages. Nerandomilast seems to be much better tolerated than nintedanib and pirfenidone. So diarrhea, again, the most common side effect, and you'll notice that the first panel is all patients. So 41% of the patients taking top dose of nerandomilast had diarrhea. But you'll recall that this included patients that were taking antifibrotics. 77% of patients were taking antifibrotics, and that includes nintedanib. So if you look at the patients who were not taking any background therapy or were taking pirfenidone, so meaning not taking nintedanib, the diarrhea incidence was much, much less, 23%, 26%. So I don't think that the diarrhea with nerandomilast, if you take it by itself, is as severe as the 41%. It's just that was the primary outcome to look at, was all patients. So if you have a little, deep dive look at the subgroup analysis here, you'll see that if you're starting someone on an antifibrotic who have never taken one before, nerandomilast's diarrhea count actually may be quite less than the 41% from the primary group. But the patient's main question for us today was, am I going to feel better? And the reality is that, when you study these medications, patients really don't report that they feel better, that their shortness of breath is better, their cough is better. So part of the management of these diseases goes beyond just prescribing an antifibrotic and sending them on their way. We have to, first of all, do a screen for other comorbidities associated with the pulmonary fibrosis. This includes pulmonary hypertension, acid reflux that could be also contributing to shortness of breath, or cough? Is their sleep disturbed? Do they need oxygen at night? Do they need to have a formal sleep study because they have undiagnosed sleep apnea? That's just happens to be along with their pulmonary fibrosis. What can I do for the cough itself? This is a very active area of research because cough is such a challenge for these patients. And I will tell you, from an anecdotal standpoint, I spend so much time talking about cough that, that may be the bulk of the visit because we've got their vital capacity loss slowed down, but they're more bothered by their cough. They can't go to a restaurant. They can't go to their spiritual services because they're coughing all the time and they're a little embarrassed by it. So we really must look at some of the other things. This could be cough suppressant. This could be other causes. It would be a shame that we're working on trying to treat their cough, but the patient's taking an ACE inhibitor, for example, that might be causing their cough. There are neuromodulators that we can try for this. Seeing a speech language pathologist for some biofeedback mechanisms to help with their cough. Lots of options to help with cough that go beyond just treating the fibrosis. Shortness of breath could be helped with pulmonary rehab, perhaps a visit to see palliative care to help with some symptomatic therapies for shortness of breath. These diseases are often associated with anxiety, depression, because we've told them they have a disease that probably will progress. We're going to try to slow the progression down, and that could affect their quality of life just because of having that hanging over their head. So seeing a psychologist, perhaps even a psychiatrist, to help with some antidepressants or anti-anxiety medicines, and also referral to support groups. There's a lot of them out there. I often encourage patients to join a support group because they can often find their people that way. And they often get tips of how to manage some of these things that even I haven't thought about before. So I learn a lot from patients because they learn from other patients, and we all share strategies to help this side effect or this comorbidity. And even beyond managing the comorbidities from symptoms, it's possible that these comorbidities may even affect the disease themselves. And this is just a slide that I often use in presentations from 2016 that show the interdependence of some of the things like sleep apnea, cough, acid reflux. They all could feed on each other and actually make the other comorbidities worse. So why we need to address all of these, because helping the sleep apnea, for example, may help the patient's cough. Helping the reflux may help the ILD. That's a bit of an area of controversy, but it's a simple thing to do. So don't ignore the other factors that go along with the patient's lung disease beyond just the fibrosis itself. We have to manage the patient as a whole, and that often includes treating these other symptoms that really affect their quality of life as much and sometimes even more than the lung disease itself. Mr. Rice is very pleased with our visit, and he thanks us today, and I thank you for listening to my talk today.
Thank you so much, Professor Kershaw, for an incredible piece of education. We've got some time for questions and answers. Before we dive into that, I'm going to bring up on screen the QR code so that if you would like to claim a CME certificate for attending today, you can do that. You just scan the QR code. I've placed the link in the chat box as well. It's a really short form. We appreciate the feedback, and you get a free CME certificate at the end. So we'd really appreciate if you could scan that and complete that. Okay, we're going to dive into some questions, and we've got some fantastic questions from our different channels. Professor Kershaw, thank you so much for joining us.
Thank you. I'm happy to be here.
We've got a question from the audience, which is, how do you decide when you add nerandomilast to nintedanib or pirfenidone, or use it as a solo antifibrotic?
This is a question that I think many of us who do this all the time are still working out, because this is very new. Nerandomilast was just approved in October, and patients are asking me this question all the time. Can I take both of these together? And so I can tell you from my personal experiences, I don't have experience with this yet because I have not tried that. In the US, you run into some issues with insurance coverage, and we don't know yet if someone's insurance is going to cover both medicines. If someone is already on nintedanib, will they even cover nerandomilast? And as I discussed in the presentation, we don't really know confidently that you're going to have an additive benefit to taking both medications. We do know that the side effects will be additive. And if you really look at the graphs about patients, taking nintedanib, for example, nintedanib plus nerandomilast, that was 60% diarrhea. So I don't know for me personally if I am ready to do that. I've had some patients ask about combination therapy. I do feel as I sit here today in late, mid to late November, that nerandomilast is probably going to rise as the number one choice solely because of the side effect profile. It's much more favorable, and the added benefit of not having to worry about lab monitoring, not having to think about what you're eating, the timing of eating is a really big advantage that that medicine has over nerandomilast, and I mean over nintedanib and pirfenidone, that I think you're going to see that rise. Now, pirfenidone is generic in the United States right now, so there is a cost advantage with that. There's a couple of pharmacies that you can go to and get it fairly inexpensively to pay out of pocket. So there's an advantage there, but we're still figuring this out. This is still very, very new. And as I, it's been really 6 weeks. And we've been prescribing the medication. I don't personally have anyone who has started taking it yet because the company has just been flooded with orders, I'm told, and they're still trying to catch up because everyone jumped on this pretty quickly when the FDA approved it.
Next question is this: Is the Envisia test still used for UIP versus non-UIP?
Um, The answer is no, not right now. And the reason for that is because there was a shortage of it was a reagent shortage, I believe, and or rather it wasn't, we were told it was a shortage, but then I found out at a recent meeting that they're making some changes to that. So there was a unavailability of the Envisia test. However, the company has sent a message that they are going to be coming back. So I currently do not use the Envisia because it's not available. And what the Envisia is, for those of you who don't know, it's a genomic classifier test that you do on transbronchial biopsy tissue. You send it away to the company and they do a look for a genomic signal that they've got proprietary data showing that it is strongly associated with UIP. So they will send you back a report that says, you know, I forget what the wording is, whether suggestive or not suggestive of UIP. It doesn't tell you what it is other than UIP. It just tells you UIP likely, UIP not likely. So when it comes back, yes, I probably will use that for those cases. You still need to use it with an MDD. In the last iteration of the ATS, American Thoracic Society guidelines about IPF diagnosis, they did not make a comment on where using the genomic classifier test lies in the diagnostic algorithm. My practice is I use it in selective cases, but in conjunction with a multidisciplinary discussion.
And another interesting question, which is there any evidence or stats on lowering nintedanib dose to 100 milligrams twice a day?
In the original Impulses trial, they did show that in patients taking the lower dose, there was a benefit there too. It was not as much of a benefit as taking the top dose of 150 milligrams twice per day. And the dosing guideline is to start at 150 twice per day and reserve the 100 milligram twice per day dosing for medication intolerance. If you need to lower the dose for a little while to allow the diarrhea to curtail, that's when you should use that. I do see some of my referral patients taking the 100, and that's what they were started on because out of fear of the diarrhea. Well, let's just start you on the lower dose instead of the 150 without even trying to see if they could tolerate the 150 first. My practice is, as it really should be the standard, is to start at the 150 and then use the 100 because it's not an all or none phenomenon. It's not like if you can't tolerate 150 twice per day, you will get no benefit if you take 100 twice a day. That's not true. You do get a benefit. It's just not quite as much as the top dose.
Another forward-looking question, which is, are there any emerging or specialized biomarkers that you find particularly helpful in differentiating PPF from non-progressive forms of ILD?
I will be honest, there's none that I'm aware of for this. I have seen some data recently using some machine learning logic and even artificial intelligence to help with differentiate some of those cases where the algorithm, proprietary of course, would take all of that information you send away the clinical data, and then they send back based on their machine learning algorithm what the diagnosis might be. And again, it kind of gets into that UIP versus non-UIP. PPF is a clinical diagnosis. There are criteria for PPF based on a guideline published a few years ago. And so I don't know that you need a biomarker to determine that. I think a biomarker could be helpful from a predictive standpoint. Say at the time of diagnosis of someone's non-IPF UIP, will this more likely progress versus another? There's none that I'm aware of. There certainly are risk factors for progressive pulmonary fibrosis, advanced physiology. Certainly patients who have an inflammatory myositis tend to progress. Scleroderma-associated ILD tends to be a little more progressive than some of the others and have a poor prognosis. But as far as a biomarker, there's nothing that I'm aware of right now available that helps that.
Professor Kershaw, thank you so much for joining us and for taking so many questions and for an amazing piece of education. We're really grateful. I hope those of you who are in the audience have found that really helpful as well. Professor Kershaw, thank you so much for joining us.
Thank you once again for having me. This was great.
I'm going to pull up on screen again just that QR code. And if you would like to claim your CME certificate, you just need to scan that QR code. The link is in the chat. On the right-hand side of your screen on desktop, just click the little message icon on mobile, and you'll be able to find that link to claim your CME certificate. I'm just going to leave that QR code up there for you to scan for a second. I just want to say thank you so much for joining us. It has been a real honor to host you. I hope that today's session has been really helpful for you. I hope that you'll join us at one of our future sessions, and thank you so much for being with us today. Have a great rest of your day.